Hi, Micah, thanks. So yeah, I'm Reagan Taylor. I work at UNMC in general medicine, and I am the committee chair for the awards committee. And for what has been a really challenging last couple years in healthcare, it is nice to be able to do something positive and reward people for all of their hard work, not just pandemic related, but just in the work that we do regardless of a pandemic or not. And so that being said, I'll go ahead and start handing out awards. The first one that we have is the Volunteerism and Community Service Award, which was initiated to honor members of the Nebraska chapter who have distinguished themselves in voluntary service in medicine. And we are very excited to give this to two folks this year. The first of which is Dr. Jennifer Brown, who is a board certified internist for Nebraska medicine. She graduated from Creighton Medical School and completed her residency and chief year both at UNMC. She is currently employed at she has been employed at the Grand Island VA and is currently practicing inpatient and outpatient medicine at Nebraska Medicine IMA in Grand Island. She is the co-medical director of the clinic and chief of staff at Grand Island Regional Medical Center, as well as she serves on numerous hospital committees at CHI St. Francis. And then our second winner of this award is Dr. Isaac Berg. He's a board certified internist that practices at Grand Island Health Center in Grand Island, Nebraska, and is affiliated with CHI Health St. Francis. He graduated from University of Nebraska College of Medicine and did residency at UNMC. And he also serves on various hospital committees and is active in precepting physician assistant students. Both of these folks were elected as a result of the efforts that they put forward, knowing that Grand Island and Hall County was one of the initial sites of the pandemic outbreak in Nebraska and their work. We did not want to have that go unrecognized. So a little congratulations to them. I don't know if either one wants to say thank you. Like, I certainly want to give you the opportunity, but no speech is necessary. So I'm happy to just move on as well. So our next award is the Humanitarian of the Year award. And this award is given for outstanding contributions to humanism in medicine and recognizes scholarly activity in literature, philosophy, and ethics. And our winner for this award is Dr. Teresa Townley, who is an associate professor of internal medicine and pediatrics at Creighton University School of Medicine. She is the director of the academic service learning and director of the rotation with the Institute for Latin American Concern in the Dominican Republic, as well as a course in global health for senior medical students at Creighton. As a core faculty for the internal medicine residency, she took lead in addressing healthcare disparity. She practices internal medicine in the hospital and clinic at Bergen Mercy campus. She's a sought-after mentor and collaborator with medical students, residents, and fellows. She is regionally and nationally known for the clinical teaching of internal medicine, as well as developing curriculum and competencies in global health and healthcare disparity. So congratulations to Teresa. Our next award is the Leroy Meyer Dedicated Teaching Award. And this award honors the physician who exemplifies the talent, enthusiasm, and professionalism demonstrated in medical education by Dr. Meyer. And our award winner this year is Dr. Brian Mullane. He is an assistant professor at the Department of Internal Medicine in the Division of Nephrology at UNMC. He received his medical degree from Edward Via College of Osteopathic Medicine in 2013 and completed his residency in internal medicine at Verde Valley Medical Center in 2016. He completed his fellowship in nephrology at UNMC, and Dr. Mullane is grateful to the faculty, house officers, and staff within his division and department who make practicing at Nebraska Medicine so rewarding. He enjoys his role in teaching medical students, PA students, internal medicine residents, and nephrology fellows. So congratulations, Dr. Mullane. Our next award is the Early Career Physician Award. And this recognizes an ACP member who has been a major contributor to the ACP, either locally or nationally, and is within 16 years of medical school graduation. And so the winner for this award is Dr. Paul Milner. He is a board certified internal medicine and works as a hospitalist at CHI Health Bergen Mercy Medical Center. He graduated from West Virginia University Medical School and came to residency at Creighton University Medical Center. He began working with the Nebraska ACP during his final year of residency training. acting as the Vice Program Committee Chair in 2016 and serving as the Program Committee Chair in 2017. Currently, he works as a core faculty member at the Creighton University Internal Medicine Residency Program with educational focus on point-of-care ultrasound training and leads the program's resident recruitment efforts. In addition, he serves as the course director for the fourth-year medical student sub-internship and internal medicine capstone courses. So congratulations to Dr. Milner. The next award is the Hospitalist Award, and this is given to a chapter member, fellow, or master who has performed the duties of a full-time inpatient internal medicine specialist or hospitalist with expertise and dedication, as demonstrated leadership in quality improvement in education, has consistently delivered high value and evidence-based care provided in a patient-focused manner, exemplifying the highest standards of professionalism. And our winner for this award is Dr. Tabitha Mathias, an assistant professor and academic hospitalist at UNMC. She graduated medical school from Kansas City University and simultaneously completed an MBA at Rockhurst University. She has served in the US Army and completed her internal medicine residency at Tripler Army Medical Center in Honolulu, Hawaii. As a hospitalist, she has enjoyed teaching residents and medical students by creating and directing educational programs in acute illness simulation and point-of-care ultrasound. She received the William Osler Teaching Award in 2016 for this educational work. Over the past few years, she has led the clinical operations of the UNMC Hospital Medicine Service as an ever-changing and ever-growing 24/7 inpatient service. She currently serves as the Associate Division Chief of Clinical Operations for the Division of Hospital Medicine. So congratulations, Dr. Mathias. Our next award is the Walter O'Donoghue Jr. MD Award. And this award honors a physician who embodies the qualities set by our late friend and colleague, an ardent supporter of the Nebraska chapter, great leadership, scholarship, and mentoring in his or her career. And our award winner this year is Dr. Carolyn Manhart. She's a general internist at the CHI Dundee Clinic who received her medical school and residency training at Creighton University School of Medicine. She's been involved in ACP as the chair of the awards committee, as the program director of the state meeting, and as a member of the Governor's Advisory Council. She's worked with hundreds of medical students and residents in the clinic, hospital, and small group settings. Mentoring students and residents in primary care medicine has been a highlight of her career. Dr. Manhart has been active in the Omaha Guild of the Catholic Medical Association for many years and helps to mentor medical students as they grow into their vocation of healing. Dr. Manhart and her husband Nick have 5 children. So congratulations, Dr. Manhart, for this award. And then our last award today is the Chapter Laureate Award. And the Laureate Award honors members of the ACP in Nebraska who have demonstrated by their example and conduct an abiding commitment to excellence in medical care, education, and research, and in service to their community and to the ACP. And the winner this year is Dr. Bruce Houghton. Dr. Houghton is an associate professor of the Division of General Internal Medicine at Creighton University. He received his MD from Creighton and completed internal medicine residency at Creighton University as well. And he joined their medicine faculty following residency. He serves as clerkship director of the internal medicine clerkship at Creighton. He has lectured, presented posters, and conducted workshops dealing with the topics of medical education, teaching, evidence-based medicine, and the use of information technology at various regional and national meetings, including the Society of General Internal Medicine, American College of Physicians, and the Clerkship Directors of Internal Medicine. Dr. Houghton has been active in medical education and has been recognized for his work in medical student and resident education with various awards from Creighton University. So we congratulate Dr. Houghton for this award as well. Those are all of our award winners this year, and we really do want to take a moment. We can clap for them, even though they can't hear us. And I want to just offer up, if any of you have people that you think should be nominated or considered, we will send out an email asking for that, but we are open to hearing about these folks at any time in the year, and we'll certainly make note. Because we all, I think, work with very deserving folks who we would like to recognize if we can. So please reach out to me, reach out to Micah, if you have anybody you would like to consider. And just, again, congratulations to all of our winners this year.
Thanks, Reagan. It's always great to sort of just take a moment to recognize the the great individuals that we all have a chance to interact with on a frequent basis, and just listening to the wide variety of impact that those individuals have had in their local communities, hospitals, clinics. I think it's definitely something that we should be proud of as a medical community, as a group of internists. So congratulations to all of you on your awards and your accomplishments. All right, we are going to transition to the business meeting. All right, and first up is really just the governor's report. And I'll before we flip to the next slides, I'll just sort of underscore what a privilege it is for me to be able to serve as your governor for the Nebraska chapter, and be the representative of the chapter as I interact with the National Board of Governors. It really is a pleasure to be able to do that. And I think oftentimes it may not be completely apparent what role the governor plays outside of sort of the chapter and the meetings that we have. At a national level, one of the main things is really, again, representing individual chapters, obviously for me, Nebraska, and the activities of the college on a national scale. And one of the main things that we do at the Board of Governors is review resolutions. So as you may be aware, or maybe remember, there's a spring and a fall resolutions process. And that resolution process is really the way that we can sort of provide our voice around topics that are of interest to us. And at our most recent Board of Governors meeting, which sadly had to be converted to a virtual meeting, much like today, really we listened to various comments and questions as we thought about the resolutions that have been proposed. And really there's a wide range of proposals that came up that if you have particular questions about those, I'd be happy to answer those, whether that's today or at a later date. But really there's many of the resolutions, they range from studying the impacts of having private equity firms purchasing hospitals and how that impacts both physicians and patients. There was some resolutions around the impact of the inpatient and observation status and the challenges that there is around that, both from a physician and patient perspective, again, and trying to understand the rules and difficulties that plays. And then also, some resolutions that are a little bit more focused on the individual physician. One in particular was really focused on how do we help support physician mothers who have particular lactation goals for their child, and being able to support them within that. So wide-ranging topics on the resolutions. If you have questions on that, any of the resolutions that have gone through recently, if you have an idea for a potential resolution, feel free to reach out to myself. Dr. Bittner and Dr. Hartman are the chairs of our Health and Public Policy Committee, and they'd also be interested in talking to you. Or if you want to get involved and serve on that committee, that would be another great thing as well. If Casey, can you flip to the next slide? I think the other sort of good news on the chapter level is that because of the various activities, because of the various efforts of many of the individuals on this call and that aren't on the call, we were able to achieve the Chapter Excellence Gold Level Award. So each year they sort of announce these, as you might imagine. Gold is the top, bronze, silver, and gold, which does come with a little bit of a financial prize, but it really represents a lot of hard work that both the chapter staff and all the various committees and individuals involved have played in allowing us to accomplish this award. So congratulations to really the chapter and the chapter staff for all the efforts that they put in to allowing us to achieve that. The next slide, there is a unique opportunity that you got in your sort of swag box. So this is really a good opportunity for those that are interested. It's something that's being held through UNMC, but it's an ECHO project really focused on trying to understand and then reduce health disparities as it relates to COVID-19. So if this is something that is of interest to you, there's a QR code that's on this kind of lower right-hand corner. Again, this was part of your swag box, so you can also click on that QR code within that to get additional information. I thought I saw earlier, at least Dr. Kazimyar was on, and she's playing a role within this project as well. So if you want to sort of shoot a Zoom chat to her to get more information, I'm sure she'd be open to that as well. So next slide. So I'm going to turn this over to Carol, or I don't know if Dr. Shupak, who's the treasurer, was able to join in, but provide a little bit of an update on the financials of the chapter.
I'm sorry I missed the welcome, but this is Lance Schupbach, and I welcome Carol or Casey to jump into. And I apologize. I think when Casey sent me the slides, this is it may omit some information, but it's an accurate statement of the chapter assets, which are roughly about 90,000 in liquid checking and about 60,000 in various short-term CDs that are the financial leadership has determined are kind of the best investments for the time being. There's not really too much good out there that preserves good fiduciary responsible stewardship of our chapter funds. But after this slide, we just have kind of a limited profit loss statement. And I apologize, I should have made sure that I included more detail about income and expenses, because I think it omits that really in general, our chapter, we are required every year to divulge chapter finances to the membership. We choose to do that at the meeting, kind of for discretion reasons that Mike and I and Casey and Carol have discussed, but very transparent. And as I'm sure Micah would say, I'm always very open to membership contacting me about any details about the finances of the chapter. But the slide we left out would be a more detailed description of income and expenses. In general, our fees that we pay to Carol and the Society for helping serve as our executive function and administration is the biggest item on our budget. I think it's around $28,000 proposed budget for this year. And then our other expenses have gone down because of COVID. We aren't spending as much on food and meetings over the last 2 years. We did put some back in the proposed budget for this year. But in general, our chapter finances are similar to previous years and no major changes. Of course, we rely on your dues. That's the bulk of what our income is. And then a significant amount from national and from support from the local medical schools. And so then our total income and expenses is up around the $50,000 range. And I welcome your questions now, or you can always contact me by email and it's through Carol or through Micah.
Thanks, Lance. Anyone have any questions now? Kind of pause for a couple seconds to see if anyone has questions at the moment.
Lance, we should mention that part of the reason that this shows July through September is because the new fiscal year starts July 1. And so we are only 3 months in the new fiscal year.
Thanks for that clarification, Carol. I guess the only other thing I would add is that, I guess one of the silver linings with COVID is that the reduction in travel, so hotel and airplane and those types of fees that would sometimes be necessary to participate in that Board of Governors meeting, like I mentioned, or other national meetings, has obviously been essentially transitioned to all virtual, so that is more cost effective. But I think once we get to the point of being able to be in person, there is a lot of value in being in person. So we'll continue to keep an eye on that if we need to transition the budget as we move forward and as the pandemic evolves. So, Casey, you want to flip to the next slide? So I just want to provide a little bit of a quick update as it relates to our membership. So overall, across the board, we've seen about a 3% increase in our general membership. There are various classes, if you will, of membership. So student membership is actually up a decent amount, given the fact that we've had some very active engagement from both medical schools. So great to see that increase up about 25% the past year. The other classes of membership, sort of your general membership, fellows, and then our resident and fellow physician membership classes as well. And we've seen a little bit of a decrease in those memberships over the past year, not dramatic, but a little bit of a decline. I think if you have questions about how you might be able to maximize your membership, a lot of that information can be found on the website, and you can explore, if you're a resident or fellow, you can explore what it means to be a member, what the benefits are to that membership, as well as the benefits of advancing to a fellowship status. And I think anyone from the chapter staff, Carol or Casey, or definitely myself, and any other colleagues that you have that are on the screen right now could speak to the value and benefits that they see from being a member of the American College of Physicians, whether that's in a membership status or if they've elected to advance to fellowship, which is actually a good transition to the next slide, if my memory serves me correctly, which is just a recognition of some of those most recent individuals that have made that next step to becoming a fellow. So want to extend a congratulations to those individuals. A couple of them are on the call today. So you can see all their names listed there. So the next time you see them, extend your congratulations to them in the role. And if you're interested or intrigued as to why they decided to do that, ask them that. And again, I'd be happy to answer those questions as well. I think advancing to fellowship is a great way to distinguish your role and commitment to internal medicine. The next slide is really kind of a voting item for us. So every year, the nominating committee and then the governor's advisory council looks at individuals to fill a variety of different roles within the chapter. And what you see on your screen is that slate or that number of individuals that have been nominated for these various positions. I'll just sort of quickly go through some of these. I think are intuitive and make sense. Others may not be readily apparent. The vice president role or vice governor role is really an individual that, should I not be able to fulfill my duties for whatever reason, they would be the individual that would sort of fill in the interim prior to the time that we would elect a new governor. But they're sort of the right-hand person that would interact with myself and the chapter staff. And this go round, Dr. Lauren Nelson has been nominated for that position. We have several members that have been selected to participate in the Governor's Advisory Council. That's really a group of individuals that you can think of it sort of as your cabinet, the presidential cabinet kind of thing. Really individuals that are across the state in various roles that serve as a sounding board for ideas and thoughts about how we should run the chapter. So a very important role. We have several that are renewing their membership to that. And then a new member, Dr. Cortez Penfield, was selected. The other officer roles, I think, are relatively self-explanatory. If you have any of those that sort of jump out as being interested in them, I would put a plug into reaching out to those chairs. If you want to be on the awards committee and work with Dr. Taylor to recognize people in the future, I know she would love to hear from you. Similar for the other chairs and their roles as well. And then the last one, just to highlight, is some of our student representatives. So we do have a student representative from both colleges. We happen to just need a Creighton student representative nominated this go round, as we already have a UNMC one. But that is the current slate of memberships, current slate of nominations that the membership needs to vote on. So Carol, if you want to pop up the next string, I think it's a poll for individuals sort of in block to vote whether you approve or disapprove of the nominating slate. So we'll give everyone a little bit of time to accomplish that. It's another time where our Jeopardy-like music would come into play, but all right, 100% approval. That's fantastic. All right, let's move on to the next slide. And I don't know if Dr. Hayes is still on. I'll provide a little bit of context. If he wants to jump in, he can. But I think the Early Career Physician Council is really working and trying to partner with others to develop a bit of a mentoring program. So this is something that is working to get kicked off the ground. So this would be for anyone that's interested, whether on the student resident side of being a mentee, or physicians that want to be the role of a mentor. And I would argue that residents would be great mentors for students as well as they transition from that sort of student to residency mindset. Something that's we're anticipating starting this fall, and Dr. Hayes is sort of the point person for that. So if you have questions or comments, feel free to reach out to him. And his email address is on the screen. And I don't know if Dr. Hayes, if you're still on, if you want to comment at all.
Yeah, thanks, Mike. So we initially had some interest and then didn't have as many people respond with some just kind of basic information about trying to match residents, students, basically match mentees to mentors to try to maximize the benefit they get out of this. So, if you have any questions, you can email me there or type me up just kind of a few sentence biography so we can post it. We have more people that want to be mentees than mentors right now, so a little mismatch, but yeah, all are welcome. Even you, Dr. Anderson.
Thanks so much, I appreciate that.
All right, go to the next slide. So there is, it's hard to believe since we're just having our 2021 annual meeting that there's already conversations and thoughts about the next meeting. And want to sort of get your guys' feedback and thoughts. There's been some initial internal discussion about maybe doing the next annual meeting at Lead Lodge, which would be a relatively short distance from many of the members who, a lot of members are from Omaha, Lincoln area. But Casey, can you throw up the questions that we have that we'd like to get your guys' feedback on? And the first one is just whether you're interested in having a scientific meeting held at the Lead Lodge. We're all hopeful that we don't have to do a third virtual meeting, that we'll actually be able to meet in person. But any interest in actually being somewhat outside of the Metro Omaha and at the Lead Lodge? Give everyone a few seconds to submit your response to that. And Casey, you want to throw up the results or go to the next question? I forget how we set this up. So looks like a majority would be interested in that. Obviously, you're not committing yourself to attending, but at least some pretty significant interest in pursuing that. The next question I think is really around what that meeting should look like from a timing perspective, whether there would be interest in sort of a Friday evening and maybe Saturday morning type of session, or Saturday only. Obviously, for those that haven't been to the Lead Lodge, it is a great place to go, with your family, especially that time of year. Lots of change in color of the leaves and some other activities that are available. So thoughts on what that schedule might look like from a day of the week perspective, Friday and Saturday or Saturday only? All right. Perfect. So this is definitely helpful as we begin to plan for that next year. And I'll just put another plug in. I know Dr. Anderson would agree. Any individual that's interested in participating and sort of developing what that program would look like on Saturday at Lead Lodge, if that's the way that we continue to pursue, feel free to reach out to myself or Dr. Anderson or anyone on the chapter staff as well. All right, next slide. So I think, transition to the town hall, and really this is just an open forum for individuals to ask questions to myself or Carol or anyone else that's part of the Governor's Advisory Council. So if individuals have questions, feel free to come off mute. Feel free to throw them in the chat as well. So anything related to the business meeting that we talked about or questions that you may have. I do see that Dr. Hartman sort of put in a plug for signing up for the Advocates in Internal Medicine Network. I would echo that. That's really, it's to sign up. It's something that just provides you some visibility around the various advocacy types of efforts that the college is pursuing. These tend to be more at the national level, periodically sending you alerts as to what they might be engaged in, what topics they're engaged in, gives you a little bit of additional context as to policies that we may have that support our engagement on that particular topic. In addition, encouraging you maybe to reach out to representatives or senators to support our particular stance. So she did include the link in there as well. So would strongly encourage people to sign up for that. It also is important in our achievement of gold status level. Stephanie, you have anything else you want to add to that?
The only thing I guess that would be coming up as well, and maybe of particular interest for residents and students, would be the plan for Leadership Day participation. Also, I mean, faculty would be welcome to participate in that. We don't know whether that would be a virtual event again this year or if it would actually be in person. But if there are students or residents that are interested in participating, then Dr. Bittner and myself would love to hear from you.
Yeah, for those that don't know, Leadership Day is it's about a day and a half, 2-day type of event. One of those days is really providing a little bit of additional context and review of some of those key priorities that the college is focused on from an advocacy related standpoint. And then the second day is actually engaging and having conversations with either the representatives or senators or their staff around some of those key positions. So it gives you a chance to, talk to, Representative Bacon and his representatives and others as well. So it's a good experience.
I do think it can be a little bit intimidating. And so the first day is really a good learning experience for anybody that is just interested in knowing more. And I would encourage you not to be intimidated about it, because I do think they provide a lot of information prior to going into meeting with the representatives and senators, so that you feel you kind of empowered to ask good questions and speak with them.
Any other questions or even plugs from the chairs of various committees for the chapter? This is your guys' time to ask those questions. Well, if there aren't any questions today, feel free to reach out at whatever point in time. Always happy to entertain questions, feel free to reach out to the chapter staff as well, and we can funnel them to the right individuals if you're interested in participating in a committee or just looking to get involved in some way and not quite sure how that might look. Happy to answer questions. So, well, we're going to keep moving along, and we'll transition to our next talk, and Dr. Anderson is going to introduce our next speaker.
Yeah, you bet. And before we go into our next speaker, just wanted to announce our second gift card winner, if that's okay, here as well. We have Dr. Scott Irvin is the next Amazon gift card winner. And I think Scott is actually a 4th year in, so he's not quite Dr. Irvin quite yet, but he's soon to be Dr. Irvin, graduating here next spring here. But congrats to Scott here. We'll get that Amazon gift card out to you here, okay? Okay, well, moving into our next talk. This is going to be a talk from Dr. Vasey. Dr. Andy Vasey, he's a board certified internal medicine specialist, practices at Nebraska Medicine here. He graduated from UNMC in 2006 and did his residency in 2009 and a chief year in 2010. He's one of our physician leaders for our primary care clinical program at Nebraska Medicine. And he's a colleague of mine and is very active in teaching medical students in clinic, as well as at our residency at our Midtown clinic. And he's practices both inpatient and outpatient medicine. So with that, we will go ahead and start Dr. Vasey's presentation here.
Vasey at UNMC Nebraska Medicine, talking about post-acute COVID syndrome today. So our objective today, talk about post-acute COVID syndrome here in Nebraska, the efforts that we have at UNMC Nebraska Medicine, talk about the multi-system presentation and workup of these patients, and also the role of interdisciplinary care for people with post-COVID issues. So to start off and have a patient presentation. So saw a 32-year-old gentleman with no past medical history in the post-acute COVID clinic here, who was diagnosed with COVID back in November of 2020. Initial symptoms were fevers, chills, aches and pains, diarrhea, nausea, extreme fatigue, shortness of breath, and just not quite thinking clearly. Went to his local emergency department for these issues. Part of the workup, got a CT scan, showed he had ground glass opacities kind of bilaterally. Got admitted to the hospital there for a few days. Never required oxygen, didn't get any specific treatments like remdesivir or steroids. Was starting to feel better and was discharged about 2 days in. For the first week post-discharge, things seemed to be improving. About 2 weeks in, started having more and more issues. Started having issues with his heart racing, getting lightheaded with minimal activity. Previously had been a runner. Now walking around the house, he would get short of breath. Also started having some allergy type issues. Started having rashes, kind of quite a bit of diffuse itching, certain foods causing some more upset stomach and diarrhea. We'll get back to this gentleman here later in the presentation today. So a little background information with COVID-19 here in Nebraska. As of the end of September, these are some of the numbers I was able to pull up. So Douglas County, we've had about a little over 83,000 cases of COVID, just under 800 deaths. Lancaster County and Lincoln, 40,000 cases, about 290 deaths. In Hall County out in central Nebraska, 9,400 cases and about 120 deaths here. So this just shows that the vast majority of people who get COVID infections survive. Majority of these people go back to their normal functioning. Anywhere from 20 to 30% of the people deal with post-COVID issues. So with post-acute COVID syndrome, we know that we don't necessarily know a whole lot. Things seem to change daily. From a study standpoint, definitely understudied. The NIH is in the process of starting up a trial looking at post-acute COVID called RECOVER study. That's something that's going to look at that and hopefully give us some more information on that. The CDC itself defines post-acute COVID as having symptoms 4 weeks after having your initial COVID infection. Various places define this differently. For the criteria for our clinic is we have 8 weeks of symptoms. So again, it varies a little bit as to what they say, what exactly is post-COVID. The other issue is, what do you call it? Well, people call it a lot of different things. So it can be called long COVID, long haulers, long hauler COVID. Post-acute sequelae of COVID, that's the NIH preferred name, or PASC. Post-acute COVID, post-COVID, chronic COVID. There's still other ways people refer to this. So as for symptoms of post-COVID, so the initial symptoms or reports out there in the literature actually didn't come from medical professionals. It came from groups of patients that got together that surveyed other people who had COVID infections and put out a publication saying these are the most common symptoms people have with post-COVID symptoms. They actually preferred calling this COVID long haul or long haul COVID, and they are the ones that actually kind of coined that term of things. So the symptoms: shortness of breath, chest tightness, fatigue, chills, continued cough, elevated temperature, headache, and brain fog. Now, various publications that came out after this was May of 2020, all the other publications that came out from various places, whether the US, Italy, other countries, really kind of had the same type of symptoms that were reported the most commonly after that. So post-acute COVID, why does it happen? We don't know for sure. Some of the thoughts would be you get a COVID infection, you have direct injury to that organ and thus have those issues related to that. Another thought is you get the COVID infection, you get some autoimmunity generated, then you attack various parts of your body from that standpoint. Another thought is people have prolonged viremia, or they have COVID pockets or reservoirs of COVID that get released over time and cause some of these breakthrough infections. So this kind of takes into account people that have the waxing and waning of symptoms, where they'll be more towards normal for a while and then they'll have worsening of their symptoms, get better, get worse. Another one is mast cell activation. So people have their mast cells inappropriately get activated and release extra histamine, and that causes a lot of the different symptoms that people can have post-COVID. What's the right answer to this? Nobody knows. When you look at people who present, some people kind of fit into one bucket or maybe another. Again, potentially it's a combination of things or different for different people. So to turn now a little bit to what we're doing here at Nebraska Medicine with our post-acute COVID clinic, talk a little bit about how it came to be. So back about a year ago, a group got together to talk about the issues that we were starting to see, people who had COVID infections that had continued issues. At that time, there were a handful of programs around the country that were starting up post-COVID clinics. University of Pennsylvania was early on, University of California, Davis, a lot of different places around the country were starting to look into that. So the group, we got a large group together to talk about this issue. So it wasn't just one person that said, hey, I'm going to do a post-COVID clinic, but we got buy-in from a lot of different subspecialties, not just internal medicine, but some of the other specialties around. So cardiology, pulmonary, ID, neurology, physiatry, along with psychiatry and behavioral health. So we had multiple people from these areas get together, talk about what's kind of been seen in their areas and what can we do about this and how do we exactly go about doing it. So one question that we had initially was, do we have everything centralized or do we not? Thinking from a standpoint of patient-centered medical home, it'd be nice to have everything in one stop. But thinking through things, not everybody needs to see a cardiologist or a physiatrist or whoever the case may be. So our thought was to say, well, we're going to start doing this in a decentralized fashion. Because not everybody needed to see a cardiologist, our thought was to have it run through primary care. And by primary care, that was me to start. So my goal was to start seeing these people, see how the process went, try to work out referral patterns or referral networks, and then opened up with other providers here. So again, the biggest kind of stretch was clinic availability. So most people have full clinics the way that it is. How do we get these people in to see different providers? So to start, we didn't open it up just to the general public. So talking to a lot of other facilities that had done this, so Cleveland Clinic, who went before us, UT Southwestern, they opened it up just to anybody who wanted to be seen or needed to be seen. They were completely overwhelmed by the amount of people that needed care. So we decided to open it up on a smaller scale to work out some of the issues that we figured we would see as we did this. So we first started it to Nebraska Medicine and UNMC employees and their families. After that initial start of things, we opened it up to anybody who was seen at Nebraska Medicine. And we're getting closer to the point of opening it up just to anybody who wants to be seen, whether referred or not. We're in the process of recruiting more physicians to work with the kind of intake of this. Right now, there's myself and 2 other med-peds providers that are seeing patients, opening it up to a few more providers after that. So post-COVID care. Well, how do we navigate things? So cardiology and both pulmonary started doing post-COVID clinics roughly about a year ago. Cardiology really started it more so from the standpoint of return to play, so kind of younger athletes who have had COVID infection, or can they safely go back to their sport of whichever sport that may be. Pulmonary started a few months after that for a lot of these people who were in the ICU, who were very sick, who were oxygen dependent and needed care outside of the hospital. Now, what we found is a lot of these people that got sent to these, whether cardiology or pulmonary clinic, really didn't have issues that were in those specialist area of expertise. So people that were having more brain fog and fatigue were being sent to pulmonary because the provider didn't know who exactly were seeing patients, and they sent them there because it said post-COVID clinic in the clinic name. So really not the best use of a pulmonologist or a cardiologist time to deal with issues such as neurologic issues or psychiatric issues. So our goal was to really, like I said, funnel this through primary care. So the initial visit, the goal of the initial visit is really to find out what's going on with these people. So you'd hear a few things from sometimes with the referrals, you'll get some paperwork, but really kind of getting down to the heart of what's going on with these patients here. The other thing is saying, well, what's been done and what else needs to be done. So Mayo, for example, their post-COVID clinic, the Mayo way is they do all the testing up front, and then they meet with the patient and then go over what's abnormal, what's not abnormal. Trying to be financial stewards, that's not really a cost-efficient way of doing things. A lot of these patients have had issues working, so finances are definitely an issue there. So racking up a bigger medical bill, really not probably in their best interest of things. So our goal is to say, well, what kind of things do we need to do to further, take care of this patient? Are there other conditions going on that we can intervene upon? So as everybody knows, from post, COVID symptoms, there's no specific treatment for that. We treat a lot of different symptoms of things. So is there something going on? So some people might have some interstitial lung disease related to this. They might have some myocardial involvement. So trying to find these things out and treat those appropriately is very important. So the referrals then, that was kind of the next step, is saying, well, do they need to see a pulmonologist or cardiologist or whoever that may be? So that was kind of the next step for us to do, is say who needs to see who, and really being able to get them in a reasonable time frame. So you look at some referrals, as everybody knows, you try to refer somebody to somebody, it takes 3 months to get in there. Well, that's kind of tough when you're trying to figure out what's going on with this person to try to get them the care that they need. So we really worked on trying to get an internal referral network where people could be seen in a little more timely fashion. And again, having, say, cardiology and pulmonary, which were some of the more common referrals, having their own specific post-COVID clinics was a helpful thing for that standpoint. Another thing we kind of discussed early on is saying, do we see these people once from an internal medicine standpoint, have them go see a subspecialist and have them just go back to their primary? Or do we have them follow back up with, say, me, for example, and try to kind of really put everything together for the patient? So our thought was saying it was probably better to have them have at least a follow-up or two after the fact, whether that be in person, telehealth, or even through portal message. We thought that that was going to be an important thing here. So not just putting this all back on to a primary who might be somewhere else who doesn't have access to all the information that was done. So what are the things that we've seen here in our post-COVID clinic here? So one of the most common things we see are people with pulmonary complaints. So shortness of breath, whether that's with exertion or at rest, cough, some oxygen dependence. And now pulmonary, they've seen a lot more people that were just, sent from various places that were, ICU type patients that were sent after the fact there. We've seen a few people in our clinic that are still on oxygen. The vast majority of people that we've seen have been people that have been moderately sick at best. I think I've seen 2 people that had been hospitalized in total, 1 person that was in the ICU. But the rest of these people were sick, really, though they didn't, seek a whole lot of care at the time, or if they did, they were given symptomatic care. So another kind of thing, whether related to pulmonary issues, fatigue or not, kind of thinking, sleep apnea. So common things being common, sleep apnea is a very common thing. It's one of the things I've probably found the most in these people in the testing that I've done. So of the testing I've done from a pulmonary standpoint, the most common tests I've gotten are PFTs or sleep studies. So PFTs kind of vary as to what we see. Most times they're normal. There are times that you can see some reactive airway disease, so kind of an asthma type picture, or probably the most common in the PFTs are decreased diffusion capacity. Now, what's the significance of that? Well, I really don't know. The one thing with that is if you have an abnormal pulmonary function test, it makes it a lot easier to get a person a CT scan, seeing do they have some sort of structural disease. For the people who happen to have had imaging when they were first ill, so they went to the ER, got X-rays, CTs, a little easier to get things approved there if they have abnormalities then. So if they had an abnormal CT with ground glass opacities, they're still short of breath, a little easier to argue that with insurance to say, well, we need to do a CT now. I found that if a person does have abnormal PFTs, a lot easier to get the CT though. Again, sleep study, another thing that's shown a lot of positive results from, that a lot of people have sleep apnea, probably more so than I've seen in my own clinic population of things. Most of these have been home sleep studies. Now a lot of insurers are going back to their pre-pandemic rules of saying people have to have in-lab studies, but for the vast majority of people, the home sleep studies work really just as well. So as I kind of mentioned before, the most common thing I see, decreased DLCOs. Some people, you'll see a little bit of blunting of their graphs that show kind of vocal cord dysfunction, so kind of an extra thoracic obstruction of things. And then with the imaging, most times normal, but sometimes you'll see some ground glass opacities persist. Another very common thing we see here is people with cardiac type complaints. So people with chest pain, shortness of breath, whether rest or activity, a lot of the kind of autonomic dysfunction, tachyarrhythmia type things. Most common things we do there, EKGs, Holter monitors, potentially echoes, potentially troponins and stress tests as well. So a lot of the people that I've seen in the post-COVID clinic actually already saw cardiology before me. So a lot of the people I've seen already had a lot of these things done. Now, for the people I've seen that haven't seen cardiology, do I do all these tests? Well, maybe, maybe not. Cardiology will do a lot of cardiac MRIs on these people too, getting a better picture of their myocardium. That's a test that I can say I've never ordered and really don't see myself ordering that one per se. I think that having a cardiologist be the one in charge of that probably is a reasonable approach of things. So the kind of different things that we've seen, a lot of just kind of tachycardia type issues. So on event recorders, seeing sinus tachycardia, various types of ectopy, premature atrial or ventricular contractions, a little bit of some supraventricular beats. There's reports of new onset arrhythmias post-COVID. I haven't seen those myself, but it's been reported that that can be an issue that people see. Another very common thing we see kind of deal from the neurologic or psychiatric aspect of things. So the type of symptoms these people present with are a lot of things like dysautonomia, whether that be kind of tachycardia type issues, neuropathy issues, a lot of deconditioning, which whether that's neurologic, cardiac, or pulmonary, well, it can kind of fit in all of those. The fatigue and brain fog are probably, again, some of the more common things that we see in a lot of these people. And these are usually the ones that are the most meaningful to the patients. These are the ones that are making them to the point where they aren't functioning the way that they're needing to or wanting to. See a fair amount of people with new onset headaches, anxiety, depression, PTSD from a psychiatric standpoint of things. A lot of sleep issues as well, whether that's falling asleep, staying asleep, nightmares and things like that. From a neurologic workup, there's some people who have put out their guidelines of what they do from the standpoint of workup. And some of them say everybody should get a MRI of their head. Probably a little bit overkill for a lot of these people. Now, if somebody has some focal deficits, then that's a little bit of a different situation there. But generally, don't start with MRI on these people. One of the tests I've felt has been really helpful is neuropsychiatric testing here. So a lot of these people are having that brain fog, kind of the memory issue, recall issues, where neuropsych testing can give a lot of information about what type of issues that they're actually having. And not only that, they can give some suggestions of what they can do to deal with that. We use neuropsych testing a lot for dementia type issues, which we're looking more to say, hey, is this more of an Alzheimer's type, a vascular type, Parkinson's type? Not really using it from this standpoint, but more from the memory issue of things. Issue with that is, I'm sure with a lot of other places, is getting people in there. It takes a month or two to get people in for neuropsychiatric testing. Another thing that I've used quite a bit here is our behavioral health specialist. So with our patient-centered medical homes, we have behavioral health providers embedded in our clinics. So to make a referral to them, it's very easy. You say, let's talk to Mike down the hall. So the behavioral therapists, what they're able to do, there's a lot of things they can do. They can do some of the memory type issues, so they can talk about various things that people can do about memory. Now, they're not, neuropsych trained, but they can help with that, especially if it's a standpoint of getting, a person in 2 months down the road. What can we do in the interim for these people? They also can help out with a lot of the psychiatric issues these people have. A lot of people who have never had issues with anxiety or depression before in their life, post-COVID, are now dealing with those issues. A lot of people have it beforehand. It's even worse afterhand. So they can work with various cognitive behavioral techniques to help out with that. Autonomic reflex testing, I've gotten that on a few people here, looking at some of the dysautonomia here. It can give you more information if you're concerned about posterior orthostatic tachycardia syndrome. All right. As with neuropsych testing, it takes 2-3 months to get people in for this. With the neuropathies that people develop with this, sometimes EMGs, nerve conduction studies, can be helpful. And again here, kind of as I talked about before with pulmonary sleep studies for the people with the fatigue and brain fog, can be a helpful test. Other things that we kind of screen for in the clinic here is chronic fatigue syndrome. So a lot of these people meet the diagnostic criteria for chronic fatigue syndrome. So as you guys know, with chronic fatigue syndrome, it's a constellation of symptoms. So it's a lot of people not being able to function the way that they did before they got sick. Excessive fatigue when they do things, kind of cognitive issues when they do things, unrefreshed sleep, and then potentially some orthostatic type symptoms here. The reason that's important is there's some things that have been shown to be sometimes helpful in a chronic fatigue syndrome. So there are things like the SNRIs or the tricyclic antidepressants that can be used, gabapentin, pregabalin. Some of those medications can be helpful from a chronic fatigue standpoint of things. The other thing is posterior orthostatic tachycardia syndrome. So I've seen a handful of people who have really met the have had neuro or have the testing, so the orthostatic type testing on this, where their heart rate jumps more than 30 points after standing for at least a minute, where their blood pressure really doesn't change, which can then be confirmed with the autonomic reflex testing here. Another kind of common complaint we see people with is allergies. So whether that's people had allergies before they're worse, there's some of that, but there's people who have never had allergy problems before that after getting COVID have a lot of issues there. So, kind of thinking what kind of the symptoms go along with allergy. Well, there's a lot of different things. So yes, there's, rashes, kind of flushing. You can have dyspnea, from an allergic standpoint, the itching, wheezing, congestion, hyperacidity, diarrhea, headaches, a lot of different things can be seen there. So referring these people for allergy testing, and then another test sometimes done, we do tryptase levels. So thinking of the mast cell activating syndrome. So with mast cell activating syndrome, as I kind of talked about as one of the potential mechanisms as how post-COVID happened, these were people that for the diagnosis of it, they have to have at least 2 symptoms that go along with this, which could be, some of the allergic things like, pruritus, rashes, wheezing, tachycardia issues, lightheadedness, GI issues such as hyperacidity, so GERD, diarrhea, different things like that. So they have to have 2 of those things. Some of the symptoms that don't count for that are part of the diagnosis, are brain fog and fatigue, but they don't count towards the diagnosis. So if you have those, that's great, but you can't use that for one of your 2. The other kind of part of the diagnosis is these people get better on antihistamine or anti-leukotriene type therapies. A lot of other issues we kind of see here, kind of, ear, nose, and throat kind of complaints, really taste and smell. So this goes from, it's a little bit of a nuisance to a patient, or it's to the point where the patient is now malnourished because they can't eat anything because everything smells like burnt garbage. Now, you hear that from a lot of different people. That's kind of what everything smells like. So there's a lot of variation in that. Dr. Barnes here in ENT sees a lot of people with smell issues. One of the best things that we can do for this is really smell training exercises. So how that works, well, you get various scents. A lot of times you do essential oils where you have a patient smell that for 30 to 60 seconds and kind of visualize what they're smelling to try to retrain those nerves. We see a lot of just kind of diffuse musculoskeletal type complaints here. So most people have aches and pains, not necessarily true arthritis, but more arthralgias of things. There's some reports of some autoimmune type issues, rheumatologic issues occurring post-COVID, or worsening of pre-existing conditions here. Workup here, inflammatory markers can be done. Some places do these a lot more. Some places check, IL-6 levels. Now, what am I going to do with an IL-6, level? I don't really know what I'm going to do with that. But that's something to consider, saying, is there some sort of inflammation going on? What we know post-COVID, some people do have chronic inflammation. We don't know the source of it, but you check their inflammatory markers, they're mildly elevated. Imaging potential here, depending on what their symptoms might be. So imaging of ankles, knees, other joints might be helpful for these people. So kind of going back now here, back to our patient that we had, our 32-year-old gentleman. Since we left him off here with kind of his worsening of symptoms, got in actually to see a couple different specialists before he actually saw me. He saw cardiology. So cardiology, got a Holter monitor, of course, got an EKG, got an exercise stress test, cardiac MRI, saw pulmonary, got pulmonary function test, saw allergy, got a tryptase level as well. So what these showed on this gentleman here is really not a whole lot. On his Holter monitor, he had some tachycardia, a few runs of SVT. His exercise stress test was normal. Cardiac MRI showed no myocardial involvement. Pulmonary function tests were normal. Tryptase was also normal. This was again his initial CT scan that he had. When it was repeated, showed that it was markedly improved. This was a few months after his initial scan. So after he saw cardiology, he got put on propranolol. I think that they picked propranolol because he was having some headaches. They said, well, maybe it'll help with the headaches too, since it crosses the blood-brain barrier. Problem is, he felt awful on the propranolol and he stopped it. So somebody had ordered autonomic reflex screening, which he actually had done just before he saw me. That came back showing that he had an excessive heart rate response, which could be consistent with posterior orthostatic tachycardia or dehydration or deconditioning. So when I saw him, we talked about things here. We talked about what was done, what other kind of things might we need to do. Now this guy, again, saw a lot of the subspecialists already and had a lot of the testing done. So we discussed, talking to cardiology again about other medications for POT versus trying metoprolol. He, said, well, let's go ahead and let's do metoprolol. So we said, okay, we'll do that. We'll give it a try, see how you do. Started him on that. Now this guy, again, had been a runner before, now gets kind of tachycardic and short of breath doing minimal activity. Talked to him about seeing one of our physiatrists out at Madonna to go over what kind of things they could do there, kind of get on a good regimen to get back kind of the incremental activity. So referred him out to PMR. So saw him follow up in 3 months on the metoprolol, went and saw a PMR, got started with the autonomic rehab out there, kind of the incremental increases. And 3 months after starting this, he was back to jogging. Now it wasn't, the distances he was doing before, but he's doing much better. So, the question kind of arises, was it something that we did? Was it, potentially? A lot of it's time. So a lot of people that I've seen have various issues that get better with time. We don't necessarily do anything, but they do get better. So one of the issues people have is, post-COVID, is they feel isolated with things. So they're feeling horrible. They're not functioning the way that they are. They feel alone in things. Sometimes they hear from people that what they're experiencing is not real, that it's just made up in their head. So it can be definitely very tough for these people. So there's various things that they can do to try to help show them that they're not alone in this here. So there's a lot of different resources online. There's various Facebook groups. There's pros and cons of that, but that's some place they can connect with other people that are having some similar issues there. There are a lot of different online blogs and vlogs of people talking about their experiences, what they're going through, maybe what's helped them. There's a website here. It's from a group that was put together of the founders had COVID and had some of these issues afterwards, called Survivor Corps. So if you go to the website here, it pulls up, it has just a lot of different information for people to go over. So some of the acute type issues, some long COVID issues. There's a lot of webinars they have links to there. There's actually physician resources that links to, CDC stuff and some different things from that standpoint. So it's not just for patients, but again, patients can get some information here, get connected with some different resources while they're dealing with these issues. So here's just a few of my references here. And now I will open things up to questions.
All right, very good. Thanks so much, Dr. Vasey, for that excellent talk here. if you're wanting to, you may put in a question in the chat, or I'm not seeing anything there right now. If anyone has any questions for Dr. Basie, I welcome you to turn on your mic and your camera and go ahead.
Hey, Andy, it's Micah. I was intrigued to hear the smell training. That sounds interesting. I guess my question, you commented that the majority of the patients that you're seeing to date are those that maybe don't have as significant of disease or didn't necessarily need hospitalization. But I'm wondering if you've seen anything from the severity of symptoms relate to the severity of their initial illness or not, or is it just no correlation?
Well, what it sounds like is most people who have a lot of these post-COVID issues weren't overly as sick to start with. So a lot of people that are in the ICU get admitted, they recover kind of in, however they recover after their long hospital stay. But again, it's more of the almost asymptomatic people that had very minimal symptoms and mild symptoms. I've only seen one person that was in the ICU during this, only a few people that were admitted. Are there more people out there potentially that, just aren't being seen at this point? That's possible, so.
Gracie, I was going to ask you about the autonomic reflex testing. Is that something that you have to refer them to neurology for, or is that is that an order that you could order, or how do you actually perform that?
Sure. It's actually just an order. It's read by neurology, but they don't have to be seen in neurology clinic for it. So really anybody can order it.
Very good.
Andy, could you comment on sort of the role of vaccination? I guess sort of a two-part question. One, are you seeing that patients that have been vaccinated are at greater propensity of having sort of post-COVID syndrome? And the second part to that would be, is there any role in becoming vaccinated if they weren't previously in the sort of treatment of a post-COVID syndrome?
Sure. The majority of the people that I've seen got COVID before they got the vaccine. So a lot of the, especially when we started with the employees and families, those people had got it prior to when the vaccination started. So there are reports out there of people getting the vaccine and their post-COVID symptoms going away shortly afterwards. So you can see that in the news. Have I seen anything like that? No. I think Dr. Maloney's on here too. He sees quite a few of these people out at Fontenelle. I don't know if he has seen any of that, but these people that have gotten the vaccine after having it really haven't had any, I guess, bad reactions to the vaccine, because there's the concern out there, or the misinformation saying if you had COVID, you get the vaccine, you're going to do horrible with it. There's really not any data to support that. So these people, if there's people that haven't been vaccinated, I talk to them about that. I recommend that they do get vaccinated when they're able to do that.
I just had a question about the neuropsychiatric testing. That typically, when I've referred people, is something that doesn't happen very quickly due to the volume. Has that been bolstered up so that it's easier to get people in for that?
So here they have hired more neuropsychologists for that. So a while back, it did take months and months and months. It's not as bad now. So it's actually easier to get them in there than it is to get into neuro generally.
Dr. Basie, there's a question in the chat that says, what sources of information have been most helpful for you as you try to sort through all these unique cases? I would imagine others are seeing similar things around the world, but as the understanding of post-COVID syndrome is even less than COVID itself, I would imagine it would be hard to keep up on different differentials and when and how to work things up.
Sure. I don't necessarily have a specific great source. It's just a matter of coming across various things, reading through it and seeing, does that actually make sense, or is it a bunch of misinformation and things like that. Patients a lot of times though will bring a lot of stuff in, and again, this goes from sometimes some stuff looks like it's well done, some stuff is just way out there. In talking with Jill Poole, one of our allergists, with mast cell activating syndrome, there's a lot of stuff out there because, again, this is not COVID specific by any means, but there's a lot of misinformation out there. And a lot of the groups, she says that some of the stuff that they discuss in the group are just completely way out of left field. So there's some of that which can be helpful for the patient, some of that which are not helpful for the patient. But I have one lady who actually established care with me, so I see her quite frequently. Every time she comes in, she'll bring in about 100 some pages of stuff she's printed off that she's found.
Have you seen long-term improvement? I mean, what's the longest someone has held on to these symptoms? And then
it's quite variable. The longest, it was probably just recently I saw who had it probably, I think it was June of 20, and I just saw the person in the beginning of October. So that's the longest I've seen somebody still dealing with it. And her symptoms were still pretty bothersome. A lot of the other people that have gotten towards a year that they've had some improvement. They're not fully back, but they're not as bad as they were at one point. Going back towards the mechanism of, well, what causes this? You see a lot of different kind of phenotypes of patients. You see some patients that have symptoms for a while, go away, they come back kind of more intermittent. Some people have more kind of constant symptoms. Now, I'd say the people that have the more constant symptoms, over time, those are ones that are slowly getting better. The ones that are a little tougher are the ones that are kind of will flare up and different things like that, where they have severe symptoms, better for a while, severe again. So again, it kind of goes towards, we don't know why it's caused, but again, it's probably not the same for everybody.
Okay, very good. Well, I appreciate everyone's questions, and thank you so much, Dr. Basie, for the excellent talk and for answering a couple of our questions here. Obviously, something that's very clinically applicable to a lot of us internists that are seeing a lot of these patients ourselves as well here. So
right.
With that, we're going to transition, and we're going to go to our next part of the program, which is going to be our resident abstract poster presentations here. And so I'm happy to introduce both of our finalists here. We have Dr. Audrey Lane, who is a PGY1, and she's a Med-Peds resident here at UNMC, and Dr. Maureen Choman, who is one of our third-year internal medicine residents at UNMC as well. And so I'll turn things over to, we'll start with Dr. Choman's case here first, but again, just a friendly reminder that after both presentations, we will open up a poll and you guys will be able to vote on which presentation you enjoyed the most. Keep in mind as you're listening, think about how well each presentation has originality of the concept or approach, significance of the conclusions and increasing your understanding, how logical the ideas were presented and the quality of the presentation, and its visual effectiveness, and again, how knowledgeable and conversant the presenter is during our Q&A sessions at the end here as well. So with that, we will start with Dr. Choman's case here.
We had a 58-year-old male present with 2 weeks of fevers, dry cough, and worsening dyspnea in June of this year. The patient noted that his symptoms started after exploring old buildings with dead pigeons. On presentation, he was tachycardic and tachypnic, and he required 50 liters with 50% FiO2 via high flow to maintain adequate oxygen saturations. Laboratory workup was notable for a leukocytosis of 14, thrombocytopenia with platelet count of 148,000, and hepatitis with AST of 142 and ALT of 74. Procalcitonin was also elevated to 2.65. Chest X-ray demonstrated extensive opacities throughout the right hemithorax and left lung base, consistent with multifocal pneumonia. Chest CT with contrast showed no evidence of a pulmonary embolism, but re-demonstrated extensive multifocal consolidation greatest in the right lower lobe, which was again suspicious for multifocal pneumonia. Mediastinal and bilateral hilar adenopathy and splenomegaly were also noted. The patient was started on vancomycin and cefepime in the emergency department, which was de-escalated on admission to ceftriaxone and azithromycin for coverage of community-acquired pneumonia. Further workup, including COVID testing, sputum culture, respiratory viral panel, urine streptococcal and Legionella antigens, histoplasma antigen, cryptococcal antigen, galactomannan, and beta-D-glucan were all negative. The patient's symptoms and high oxygen requirements persisted despite treatment with ceftriaxone and azithromycin. So atypical coverage was transitioned from azithromycin to doxycycline, given the history of bird exposure. After this change, he had subjective improvement in symptoms and oxygen requirements decreased. The patient underwent bronchoscopy, which showed an elevated white blood cell count with predominance of polys, but was without evidence of fungal organisms or pneumocystis. Eventually, chlamydia serologies returned positive with a psittacosis antibody IgG of 1 to 512. Other chlamydia antibody positivity on the panel was attributed to cross-reactivity. Psittacosis is rare and accounts for less than 5% of cases of community-acquired pneumonia that require hospitalization. Fulminant infection with multi-organ failure is rare, but has been reported. Birds are the primary reservoir, and nearly 500 species have had documented infection. Patients frequently present with fevers, headaches, and dry cough. Up to 25% of patients present with diarrhea as well. Liver enzymes are abnormal in approximately half of hospitalized patients, and hyponatremia is common as well. Diagnosis is made with serologic testing, as cultures are difficult to obtain, require a level 3 laboratory isolation facility, and are discouraged due to the danger of aerosolized transmission to laboratory personnel. Bird-associated diseases with pulmonary symptoms can be caused by a variety of organisms, including bacteria, viruses, like the avian influenza or bird flu that emerged in 1997, and fungi. Additionally, non-infectious causes like hypersensitivity pneumonitis caused by inhaled avian proteins can also be the cause of presenting pulmonary symptoms. Because of this, it is important to take a thorough bird exposure history by asking about wild versus domestic bird exposure, the apparent health of the bird at the time of exposure, timing since exposure, geographic location or recent travel, and whether symptoms improve when away from the bird. All this information can help guide one's differential. The key clinical takeaways from this case include taking a thorough history and maintaining a broad differential for patients presenting with pneumonia and a history of bird exposure. Additionally, doxycycline is the preferred treatment and should be included in empiric community-acquired pneumonia regimens in patients with appropriate exposure history.
All right, very good. Thank you, Dr. Choman, for that very interesting case presentation. I'll open it up to the group to see if anyone has any questions for you.
I have a question for you. Obviously, the bird exposure was a key bit of information for this particular case. Wondering sort of the timing of when you got that, and in retrospect, was there any consideration, or should there have been consideration for empiric doxycycline earlier in the patient's stay?
Yeah, so that bit of history was actually obtained on the admitting history. So we knew that right from the start. And that was kind of retrospectively why that was one of our clinical takeaways, that your atypical coverage when you have a history of bird exposure should be doxycycline. We didn't change his azithromycin to doxy until about his third day of the hospitalization, because he was still fevering pretty extensively the first 48 hours. And the biggest thing that, from what I read, you'll see when you make the transition to doxycycline is people defervesce faster.
Yeah, that was an interesting takeaway that I'm not sure I appreciated prior to that. So great case. Appreciate the presentation.
Thank you.
Do you remember how long it took you to get the chlamydial serologies back? Is that something that's like a pretty quick turnaround, or is that something that takes like weeks and you get it back after the patient's already completed the treatment course?
So it came back pretty late. I can't remember the exact timeline. It's definitely one that we send out to Salt Lake City. The other things we were waiting for were all of our fungal labs. There was concern for histo, and there was actually discussion if we should empirically start ambisome, because he just wasn't improving on the cap coverage.
Okay, very good. Thank you so much, Dr. Troman. With that, we will bring on our next talk from Dr. Audrey Lane.
Looking forward to talking to you tonight about recognizing calciphylaxis. So a little bit of background. Calciphylaxis is the deposition of calcium and phosphorus in the intima of blood vessels. It results in decreased nutrient diffusion and microinfarcts. The one-year mortality can range from 33% to 80%, with those who present with ulcerating lesions having the highest mortality. This really highlights the importance of recognizing it at an earlier stage, because a recent case series actually described complete resolution without reoccurrence in those who were recognized at an early stage and received multidisciplinary treatment. Our patient was a 57-year-old female. She was brought to the emergency department for altered mental status and right lower extremity pain. She'd been hospitalized 3 weeks prior for cellulitis and received antibiotics for this. She did not attend her follow-up appointment and had missed multiple consecutive dialysis appointments, including the 2 immediately prior to this admission. Past medical history was remarkable for end-stage renal disease, type 2 diabetes, HIV infection, depression, and a variety of other things. Her medication list was pretty extensive as well. On physical exam, her vitals were remarkable for hypertension and an elevated BMI. As I mentioned, her mental status wasn't great. She was answering yes or no questions and communicating how painful this leg was, and that was about it. And then when examined, there was a 6x5 indurated plaque on her right leg. The induration was similar to peripheral edema, but unique in that it was limited to this area, and when you pressed on it, it was almost more crunchy. She had a similar but smaller lesion on her left leg. Initial laboratory evaluation was remarkable for many electrolyte disturbances, as you might expect with someone who had missed dialysis. Also remarkable for a low vitamin D, as well as the low CD4 count, showing that her HIV infection had progressed to AIDS. We went ahead and ordered an ultrasound of the lesion on her leg. What the results of the ultrasound showed was really a limitation of the imaging of the tissue because of what they described as large calcification or calcification in this area. Because of this, we pursued a biopsy. The biopsy showed fat necrosis with extensive calcification, the calcification being both interstitially and in some areas present around small blood vessels. In this image, which is not from this patient, you can see the calcification here within the soft tissue. This biopsy confirmed the diagnosis of calciphylaxis. All right, moving on to the discussion. So in fact, 73% of people who are eventually diagnosed with calciphylaxis are initially misdiagnosed. Some of the other things that can present similarly would be cellulitis. One of the distinguishing features of this is that it's not going to respond to antibiotics, and also the pain out of proportion to exam. Finally, the characteristic induration of calciphylaxis is another useful thing to differentiate it from cellulitis. In this patient, we were also concerned for systemic fungal infection given her status as AIDS with AIDS. And other things to consider would be peripheral arterial disease, vasculitis, and then a variety of other diagnoses that may be appropriate in the clinical context. Understanding the pathogenesis of calciphylaxis provides a really useful framework to understand its risk factors. So with calciphylaxis, when the levels of calcium, phosphorus, and PTH are persistently elevated, the smooth muscle cells within the medial layer of blood vessels become osteoblast-like, and they start producing hydroxyapatite crystals and really depositing within there. This can further progress to fibrosis of the intima, and these two together increase the likelihood that you're going to form a thrombus within these small blood vessels. Understanding this, it seems intuitive that having hyperphosphatemia, hypercalcemia, hyperparathyroidism would all result in being a risk factor for calciphylaxis. And then given that the role that thrombus plays in its progression, it also is intuitive that those who are female, have diabetes, and are obese would be at a higher risk. The treatment of calciphylaxis focuses on limiting further calcification of blood vessels. This means optimizing electrolyte levels and PTH levels. This may include switching from peritoneal dialysis to hemodialysis, and can also include medical or surgical parathyroidectomy. Next, there are some options for promoting decalcification, specifically sodium thiosulfate. This can be given as an infusion following dialysis, and it can also be directly injected into their lesion. Finally, also recommending the use of direct-acting oral anticoagulants. Try to avoid warfarin in these patients because of the role that vitamin K can play in the further progression. Finally, calciphylaxis is extremely painful, so it's really important to have good wound care and pain management for these patients. So for our patient, her encephalopathy resolved with dialysis. When she was improved, we discharged her to home. Unfortunately, she had inconsistent follow-up. She missed multiple consecutive dialysis treatments. When she was seen by her primary care provider approximately 3 weeks after discharge, the area on the right lower calf had more than tripled in size. Here are some of my references, and I thank you for listening to me. I'll take any questions.
Okay, great presentation, Dr. Lane. I'll take any questions from our group here that you may have for
her. With calciphylaxis and the potential for the wounds from biopsy having issues, what are your thoughts on empiric treatment versus that need for diagnostic certainty with biopsy?
Yeah, so one of the reviews I looked at actually discouraged biopsy because, as you mentioned, there's a lot of problems with wound healing in these patient population because of problems with their microvasculature. So actually the diagnostic modality that's recommended right now would be x-rays or bone scan, because you can see the deposition of the calcium within the soft tissue. So therefore you can kind of piece together your diagnosis a little bit more solidly without having to do the biopsy.
Dr. Mullane, have you, or Dr. Mullane or Dr. Lane, have you anecdotally seen that, is this mostly related to the hyperphosphatemia, or is the secondary or tertiary hyperparathyroidism, the PTH being really high also, does it get better, or can you reverse this one by treating both those, or do you really need sodium thiosulfate once at the point that you're developing this?
I'll let Dr. Mullane speak to it after I give it my best shot, but my understanding is the goal with, normalizing your electrolytes and normalizing the parathyroid hormone is to prevent the progression. This is a progressive disease. As I mentioned, this patient had lesions on both the right calf and on the left. So the goal with that is to prevent the progression, and the thiosulfate, its role is to try and aid in the reversal, but pretty difficult disease to actually reverse once it's started.
Yeah, I would agree with that. We've actually, I would say, almost a crazy number of cases recently, and historically, there's not been an association necessarily with phosphorus and or parathyroid hormone level control. And normalizing those values doesn't necessarily lead to significant improvement in the patient's lesions. And really, the best, again, anecdotal, the real evidence is very poor, but with sodium thiosulfate, will at least lead to some improvement in some patients, but for the most part, just hopefully keeps it from getting infected and leading to mortality from those infections.
Okay, very good. So with that, we're going to put up our poll to have the audience vote here, and we'll give a couple minutes for you guys to put in your vote. And just to buy us a little time here as everyone's submitting their votes here, just a friendly reminder that the last session of our presentation after this is we're going to switch to Doctor's Dilemma here next. So stay tuned. Okay, this again was another very close vote, but happy to congratulate Dr. Lane. Dr. Lane is our winner of our resident abstract scientific presentation here. So congratulations, Dr. Lane here. Well done. You will have a kind of an automatic entrance into the national poster competition, and you'll receive a $200 cash prize here. So great work to both of you though.
Thank you.
Okay. Very good. So I'm going to turn it back over to Dr. Beachy, who's going to introduce Dr. Fox and get us started with Doctor's Dilemma here shortly.
Yeah, so I think Dr. Fox almost doesn't need an introduction. He's been a part of Nebraska chapter activities for a long time in a variety of different roles. And one of those roles has pretty consistently been to helping us sort of put together the Doctor's Dilemma. And I'm excited to be able to reintroduce that after having a hiatus last year. Obviously, it's going to look a little bit different this go around as we give it our best shot on trying to accomplish this in a virtual format. Dr. Fox, do you want to provide a little bit of the ground rules as to how we're going to accomplish this?
Absolutely. Thanks, Micah, for the generous introduction. It's an honor and a pleasure to be participating in the meeting again this year. First time we've done Doctor's Dilemma virtually like this, and so could be a little tricky, but we're going to get through it. It should be a lot of fun. What the things that look a little bit different in the format this year, for one thing, we're just doing one round. So we've got 5 categories, one round, and then a final Jeopardy, as it were, a final Doctor's Dilemma. So I'm sure everybody's pretty familiar with the structure of a Jeopardy format quiz show. Each question has a number of points from 100 to 500 assigned to it. Theoretically, I've created the questions in ascending difficulty, but that's not always the case. And the way we're going to do it for virtual, I know we've got a team at UNMC there. Good morning. And I think we have a team at Creighton as well. See if I see, oh, there they are. Hi guys. So perfect. And so what we're going to do, and I've got a couple people paying attention, we're going to ask you guys to raise your hand on the screen via the little icon when you believe you know the answer. So that's the simplest aspect of it. Now to kind of keep it fair and turn it into not just a race to who can ring in first, I'm going to ask that you not ring in until you've seen the question. However, if you're pretty confident that you know the answer, you can ring in early. But at that point, what I will do is stop reading the question, ask for your answer. And if you're incorrect, you'll be deducted those points. There will also be a deduction just if you happen to ring in and get the answer incorrect at that time as well. So again, just trying to keep it fair so we allow some time for you to kind of ponder the question, knowing that if you ring in, you're at risk for loss of those points. So anticipate a pretty good game. So I'm going to, well, any questions first off?
Yeah,
And I think Carol and Casey are going to be our scorekeepers, and I'll just shout out as we go through how the points will be assigned. So,
oh yeah, good. I was going to say, who's going to tell me how much points we're taking?
yeah, I can do that. So,
and Devin, can you hear us? Is our microphone working?
I can hear you fine.
Okay.
UNMC, can we hear you?
Can you hear us?
Yep.
Yeah, we can hear you.
Yep.
Awesome.
Dr. Fox, when we were trying this out and testing this, we realized that when the teams raise their hands, it automatically puts them very first on our screen, so we can kind of see who raised their hand first. Help us with kind of tiebreakers there.
That's great. That makes it a lot easier then. So,
and if could you clarify, if a team gets it wrong and the other team has a chance to answer, are they punished if they also get it wrong, or no?
That's a good question. I would say yes. Let's have them choose not to answer if they don't know the answer, but that if they answer and get it incorrect, that they will lose those points.
Right. Very good.
That work, judges?
I think that's just fine.
Yeah.
Okay.
One quick clarification when we're talking about raising hands for both Creighton and UNMC, under the reactions tab, there's that raise hand functionality. You will need to sort of raise your hand and then lower it too. So in between questions, we'll have to have you sort of reset the buzzer, if you will. And by utilizing that function, we can kind of see who raises their hand first on our end. So I think the only other thing we were going to do quickly before we sort of get into the official Doctor's Dilemma is have each team sort of introduce the members. So Creighton, do you want to go first? Just introduce yourself and maybe what year of residency you're in.
Yeah, good morning, everyone. I'll start. My name is Abidel Anani. I'm a third-year internal medicine resident. It's nice to see you all.
And I'm Yaman Alali, a third-year resident too.
I'm Abubakar Tasiyo, a second-year resident.
And I'm Yazan. I'm a third-year resident as well.
All right, great. UNMC, can you do the same?
Yeah, I'm Pete Maloli. I'm a third-year resident. I'm Joe Pachunga. I'm a fourth-year med peds resident. I'm Jack Gallagher. I'm a second-year internal medicine resident.
I'm Alex Sorek, second-year resident.
We just had one question to clarify. So we can't raise our hand until the question's completely read, or what's the rule on that?
Thanks for the question. So you can raise your hands early, but at that point, I'm going to cut off reading the question and ask for your answer. So if you raise your hand early, you don't get the benefit of the entire question. Does that make sense? Because what I'll be doing is reading the question, and when I complete the question, that's when I'll flash it up so you can actually see it.
Dr. Fox, will there be a time limit for the answer?
No.
All right, thanks.
Not like 5 or 6 minutes though, please. So, all right, are there any other questions? And I do have Nate and Micah, I think, and Suzette had volunteered to be my judges. They've seen and reviewed the questions.
We're right here.
What's that?
Yeah, we're here.
Okay, great. Yeah, so the questions have been reviewed. I did get some feedback, and the judges may weigh in that the answer that's visualized, that we may accept other alternatives. And so in real time, we'll throw it to the judges for any adjudication there. But are we ready to go ahead and jump in? Great. I'm going to share my screen here if I can remember how to do this. And is everybody able to see the screen? Great. I'm going to launch into single Jeopardy. I flipped a coin earlier. I'm going to refer to Nebraska is team 1 and CUMC is team 2, just for the purposes of simplicity. And also the coin toss allowed Nebraska Medicine to choose the first category to tee it off. So our categories for Doctor's Dilemma this year include pulmonary pearls, history of medicine, endemic diseases, before and after, and name the eponym. And it's possible that if neither team is able to answer, I might throw it to the audience. Usually Dr. Bittner's got these figured out. So I think I saw him on the show. So we'll see, because some of these are in his frame of mind, particularly the before and after ones. So, all right, team 1, Nebraska Medicine, which category would you like to start with?
You're muted.
We'll do history of medicine for 100.
History of medicine for 100. Hippocrates, the father of modern medicine, systematized the thinking that illness can be explained by an imbalance of blood, phlegm, black bile, and yellow bile, the 4 of which are collectively referred to as this.
UNMC.
The humors.
That is correct. 100 to Nebraska. Good job. And usually what I do if the teams agree is I just go ahead and go on down the category if that's acceptable to everybody. Just keep it simple. All right. So on to 200. This author of Ars Medica, through the process of animal dissection, came to the conclusion not only that the heart is responsible for the circulation of blood through the body, but also that it is the home of the soul.
Who is Leonardo da Vinci?
I missed who that was.
Oh, we had raised our hand. I think we raised our
Oh, I
hand.
see there. Okay. Unfortunately, that's incorrect.
Minus 200.
Creighton, you can either guess or just pass.
We'll pass.
Okay.
Evan,
So
real
that-
quick, I think for both teams, just stay unmuted unless
Yeah.
we end up getting a lot of feedback. So UNMC and Creighton, just leave your video unmuted.
That's a good call. Thank you.
We should ask them.
All right, throw it out to the crowd. Who knows this author of Ars Medica who said the heart is the home of the soul?
I see Lance holding up his hand.
Lance Schupbach.
Is it Harvey?
Nope. Correct answer for this one is Galen. Galen. So
We had
It's
a
like
quick
Dr.
question. Just sorry. If someone gets it wrong, the other team gets the guess. Do they also get penalized if they guess and get it wrong, or is that a free guess? They get penalized for that. Okay.
penalized as well. Yep. Yeah. So, okay. So that's minus 200 for Nebraska. Now on to 300. The first medical schools were opened in the 9th century AD, the most notable of which was Scala Medica Salernitana in the southern portion of this country. Scala Medica Salernitana. Timid and hazarding a guess here. I see. That's okay. No guesses from either team? No problem. Anybody in the crowd?
Dr. Bittner has his hand up.
I knew it. Dr. Bittner.
What was Italy?
That is correct. Have you visited this place?
No.
Well, we need to get there. All right. So no harm, no foul there. That is correct. Italy, 300. We'll move on to 400. The noted book of 1803, Medical Ethics, or a Code of Institutes and Precepts adapted to the professional conduct of physicians and surgeons, set the standard for many textbooks on the subject of medical ethics and was written by this man.
I have no idea.
Father of medical ethics. I promise they get a little bit easier after this category. I want to try to have fun. All right. Okay, no guesses. Who knows who this father of medical ethics may be? No problem. That is Thomas Percival. Percival. Okay, again, no harm, no foul. Last but not least, I know someone's going to get this one. For 500 in 1847 Vienna, this physician dramatically reduced the death rate of new mothers by requiring physicians to wash their hands before attending childbirth. Yet his principles were marginalized and attacked by his professional peers at the time. I saw a hand up there, I think, both Nebraska Medicine, and I'll hold off on you, Dr. Bittner. UNMC, what's your answer there?
That makes sense.
Ignaz Semmelweis.
That is correct.
Wow, nice, dude.
Excellent work. Very good. Okay, so 500 for Nebraska. So since Nebraska has answered correctly most recently, I'll let you guys choose the next category we go to.
Endemic diseases. We'll start at the top.
All right, endemic diseases. Okay, for 100, this vector-borne parasite is acquired when one ingests larvae that reside in water fleas and is named after the west coast area of Africa.
No, it's not vector-borne.
Creighton.
What is Loa?
That's incorrect. UNMC, you can hazard a guess or pass.
Just this one.
You said raise hand.
But my hands from Chuck and my work. Why did you answer?
It's okay.
That's all right.
No guesses for Nebraska?
We're discussing.
Okay, take your time.
Yeah, those are all the ones I'm saying is, someone would, you get the, like, not the BCS. Or is it just 3 parasites? So does it 3 parasites? I don't know what it is.
Any guesses?
No guesses from us.
Okay. Guesses from the crowd.
Or does it know the answer?
Dr. Bittner has his hand up again.
Fire away, Marv.
What is guinea worm?
That is correct. Guinea worm disease or dracunculiasis, which is just so fun to pronounce. Okay, so that'll be minus 100 for Creighton. And moving on. Okay, for 200. This cause of viral encephalitis has been around since antiquity, but wasn't identified until 1937 in Uganda. It created a major stir when it got to the Americas just a few years ago.
In America.
Dr. Bittner seems to know. Any guesses for Creighton or UNMC?
All right, that's okay. Marv.
What is West Nile virus?
That is correct, West Nile. At the time, it was kind of the COVID of the moment, right? It's pretty scary, but didn't quite change our lives in the way. Okay. And we will go to the next for 300. Excuse me. Another cause of encephalitis. This bunya virus is passed from the female mosquito to her eggs, which can survive the cold winter in the US state in which it was initially discovered? Apologies to Packers fans. May be named after a city within the state in question.
Name some Wisconsin city. I don't know.
Okay, no guesses. No problem. Dr. Bittner.
What is lacrosse virus?
That is correct.
No.
Very good. Okay, well, for 400 now. This viral hemorrhagic fever is actually subclinical in the majority of people and was initially discovered in Nigeria. Its most common vector is the African common rat.
I already answered.
Creighton.
Is it dengue fever?
Incorrect.
Is it the yellow? Yeah.
Any guess, Nebraska?
I don't know, 400 points.
Okay, yeah, that's a lot of points to risk. We'll see if Dr. Bittner will risk 400 points. Or let's go to Dr. Schupbach.
I'm already in the hole. I'm already in the hole, so Ebola.
Incorrect. Sorry. Dr. Bittner, Marv.
What is Lassa fever?
That is correct. Lassa fever. And let's just do this last one to get out of this dang category. Okay, for 500. The knowledge of this flavivirus dates to 1933 when an outbreak sickened over 1,000 people. It is transmitted by Culex mosquitoes who acquire it through feeding on migratory birds. I might say it's the arch enemy of people in a nearby state. The arch enemy. Thanks, Lance. I see you laughing.
I appreciate the Socratic method that you're trying to use to lead to.
Years of experience. No guesses?
No.
All right, Lance.
St. Louis encephalitis.
Yes, St. Louis encephalitis, home of the St. Louis Cardinals. I tried.
Thank you for the clues, Devin.
You know, no one's ever accused and turned us to being nerds, have they?
You did.
Okay.
Equalizer for Dr. Bittner's.
Okay, so I believe Nebraska did answer correctly most recently. So that was 3 categories to pick from.
Yeah, I'm sure. Pulmonary pearls. We'll start at the top.
All right, pulmonary pearls.
You did pull them, you know.
Let's jump in for 100. This condition, which primarily affects the lungs, is characterized by dyspnea and cough, and bullous emphysematous changes on chest X-ray more prominent in the bases than in the apices. Creighton.
Which one?
Alpha-1 antitrypsin deficiency.
That is correct. 100 for Creighton. Okay, on to 200 here. Excuse me. This condition that presents with cough and shortness of breath is characterized on high-res CT by centralobular ground glass nodules in the mid and upper lung zones, in granulomas, and multinucleated giant cells on biopsy. Precipitating causes include molds, pigeons, and farm silo dust.
Hypersensitivity pneumonitis.
That is correct. Hypersensitivity pneumonitis. 200 for Creighton. On to 300. The definition of moderate persistent asthma is contingent upon symptoms of asthma occurring at this frequency.
You know what? Wait.
I saw Nebraska.
Click.
Likely symptoms of medical
It's not daily yet. Not daily.
Are you using the ACP card? I'm sorry.
Nebraska, your answer?
Greater than two. Yeah, so far. So greater than 2 times per week. Oh wait, or that's it, right? Is that, or do we have to do all of them or just?
This, how frequent the symptoms need to occur to qualify for that specific diagnosis.
Yeah, greater than 2 times per week and greater than 2 nights per month.
That is incorrect. I'm going to allow Creighton the chance to answer, and then we're going to discuss amongst the judges. But
it's not every night.
Creighton, do you have a guess?
Yes, so it's daily symptoms during the day and 3 to 4 nights a week.
That I have down. I'm going to throw this to the judges. According to Up to Date, for specifically it's daily, but I think Nate had some possible additional information. So I'm going to throw it to the judges to decide on the outcome of this one.
This is what I looked up on Up to Date. So they said most days. So most days it'd have to be at least 4 days of the week to qualify, and then sleep interruption due to asthma more than once a week. So I think Creighton's answer would count.
Okay. Thank you for that. So that will be a minus for Nebraska and a plus for Creighton.
Got it. Thank you.
Okay, thank you. On to 400. Sarcoidosis is a primary pulmonary condition characterized by bronchovascular nodules and hypercalcemia, and is diagnosed by bronchial biopsy revealing these pathognomonic findings.
Non-caseating granuloma.
No, we answered.
Nebraska had their hand up first there. Or did they? Actually, I'm going to go to the judges. I didn't catch it.
Yes. Sorry to interrupt. Just remember to say what is before your answer, so you don't get penalized.
Yeah, I haven't been paying attention to that. So who has the guess?
Is it us?
UNMC.
Okay.
What is non-caseating granulomas?
That is correct. 400 for Nebraska. Okay. Be sure we call on you just so that you have a chance. So, okay. And last for 500. This is the diagnosis when pulmonary function testing shows reduced airflow during expiration and inspiration with flattening of both limbs on the flow volume loop.
Fixed obstruction. What is fixed obstruction? Sorry.
Judges?
I think that is fair. Dr. Clark?
Can they elaborate more of their fixed obstruction?
It's like intrathoracic, or I mean,
any obstruction.
Any obstruction that is fixed, because you could have intrathoracic or extrathoracic variable obstruction. That kind of the fixed loop, the fixed obstruction kind of loop.
I'm going to accept the answer. I just wanted to make sure they rang in first. Appears they did.
It did look like they had their hand up. Yes.
Okay. Well, that's correct. Fixed obstruction, and it can be either intra or extra. It's the variable obstruction that looks different depending on intra or extra, right? So, and boy, do they love flow volume loops on the boards. So good thing to have in your armamentarium. So, okay, 500 for Creighton. So
Creighton?
Creighton answered correctly last. Which would you like to go to next? Before and after, or name the eponym?
Okay, we'll go with before and after.
Okay, so you'll have to bear with me on this one. This is a category we have a little fun with, and so you just have to keep your mind open.
Dr. Fox, could you explain what the answer needs to be then, or explain how this one?
Absolutely. So what this really is kind of two answers mashed into one. If you've watched Jeopardy, you'll see him do this, but I think with the first clue, it'll kind of come clear. Really, there's two answers in each of these categories. So just pay attention to the first one, and I think it'll kind of explain the rest. So I'm going to go ahead and read for 100. An arachnid whose bite leads to local pain and swelling and sometimes localized necrosis and prominent capillaries on the abdomen in someone with cirrhosis.
UNMC.
UNMC.
Oops, sorry. Go ahead, Nebraska.
Don't understand the question.
I think
So, like,
both those things.
So we're like answering both of those questions.
Yeah.
So what is a brown recluse in caput medusa? Is that what you're
Not
looking for?
exactly.
Can you explain the category more?
Yeah,
How do we answer? Like, what
Dr.
is it?
Kevin, I think we have difficulty understanding this category too.
How do we answer these questions? Like,
I think you'll see. I'll display the answer and then you'll understand it, but I'm going to go ahead and see if anybody from the crowd understands and gets it.
Spider angioma.
Okay, so the correct answer would be brown recluse spider angiomata. So we've got brown recluse spider and spider angiomata. So there's kind of a common denominator in the two answers. Does that make sense?
Okay.
Did we say that?
Now
So
that
does-
we don't quite since we don't quite understand this, I'm not going to penalize Nebraska on this one. But now that we
Okay.
do,
Okay, that makes sense.
okay,
Nebraska, put down your hand again.
good. All right, so for 200, hopefully you kind of understand now. A device implanted to relieve recurrent otitis media and the diagnosis in a pregnant female with pelvic pain, elevated HCG, and no fetus in the uterine cavity. Okay, Nebraska.
What is tympanostomy tubal pregnancy?
That is
Tympanostomy.
correct. Very good. Tympanostomy tube and tubal pregnancy.
Which has a question.
Okay, so 200 for Nebraska. Good. And for 300, this is a drug class that purges the colon like mag citrate and a condition otherwise known as trigeminal neuralgia.
Drug class that purges the colon acetate. A drug class that purges the colon. Drug class.
Any guesses?
Need two words that have one word in common.
That should moisture.
Okay. Seeing none, I'm going to go ahead and see if there's any ideas from the crowd. I have that as cathartic doloro.
Would you have accepted like Lagza Tic-Douloureux or not?
No. Okay. For 400, a rare autosomal recessive disorder leading to recurrent sinopulmonary infections and for infertility, and a condition characterized by abnormal retention of water and hyponatremia.
Hyponatremia and water retention. Hyponatremia and water retention. Water retention.
Any guesses? All right, I'm going to go to the crowd.
Cystic fibrosis, SIADH.
Not quite. I made this one Cartagener's syndrome of inappropriate ADH. Okay, last but not least, I'm really proud of this one. I hope somebody gets it for 500. Trichuris trichiura, that is also a poisonous shrub used in the fabrication of absinthe and some old medical remedies.
The fabrication of absinthe. No idea.
I like the dialogue. No guesses? Dr. Bittner, I'm going to throw it to the crowd.
Is this, what is thread wormwood?
That's a good, they're really close. And whipwormwood.
Yeah.
So, anyway, well, I'm never doing before and after again. So
That was clever.
It takes a special kind of brain, and I don't mean that in a good way. Okay. So that leads us with name the eponym. These will probably be a little bit more clear. And you don't have to name the full name of the person, just what exactly I'm asking. So for 100, this is a means of providing regional anesthesia, most often to the upper limbs via IV infusion of anesthetic.
What is it? Who they need the name of someone?
Like a person? No.
What do they?
Looking block.
And by the eponym, as we're looking for an individual's name.
Individual's name. No. Individual name.
A person who is covered.
No guesses? All right, I'm going to go to the crowd. Micah.
What is Beers block?
That sounds like someone who works in a pre-op clinic. Very good. Beers block is correct. Named after August Beer. All right. And for 200, this is a benign swelling of the semimembranosus, or more rarely some other synovial bursa, found behind the knee joint. Nebraska, or who, actually, I'm going to go to the judges. Who answered or who clicked first? I wasn't looking.
It was Creighton.
Okay, Creighton.
What is Baker cyst?
That is correct. Named after William Morant Baker. 200 to Creighton. Next for 300.
Ben's hand is still up. Sorry.
Good. Okay. For 300, a cholangiocarcinoma forming at the junction of the right and left hepatic ducts. Guesses? All right. Anybody from the crowd know the answer to this one? That is a Klatskin tumor. Gerald Klatskin. Okay, and for 400, a benign cystic tumor of the salivary glands containing abundant lymphocytes or germinal centers or lymph node-like stroma. I saw one of these one time. Creighton.
What is Wilms tumor?
Incorrect.
Oh, Warthensill. Warthensill. Sorry. Warthensill.
I have to take your first answer.
Okay. Oh.
Yes.
It's all right. Okay, Nebraska, you have a guess?
No.
Okay, no guess. Well, Creighton's second stab was correct. Worthen tumor after Eldred Scott Worthen. So, but have to take the first one. I didn't mention that earlier, but that's minus 400 for Creighton. And we will go on to 500, the hard one. This is a genetic disorder that results in the buildup of glycosaminoglycans due to a deficiency of alpha-L iduronidase, an enzyme responsible for the degradation of mucopolysaccharides in lysosomes. It is also known as gargoylism.
What is Hunter's disease?
That's incorrect, Creighton. Nebraska.
Yeah. What is Hurler's disease? Or Hurler's
That is correct. Gargoylism is Hurler syndrome after Gertrude Hurler.
Yeah.
So kudos, some hard questions in there. So what we have next is to go into final. And so I'm going to ask each team to discuss amongst themselves quietly how many points they'd like to wager. But first we want to find out how many points each team has. Carol, do you have that information?
I do. Creighton is negative 100 and UNMC is 1200.
Okay. Let's see how I'm going to ask the judges. Let's put our minds together to decide how we want to offer the ability to wager. Any ideas?
That's a tough one. Watching the game show, I think if you're negative, you're not allowed to play, but that's not very fun. I'm not sure.
Yeah, that is true. And for fairness sake, I think we probably should stick with that. But we'll go ahead and go to single for the fun of it. How's that sound?
Okay with me. I think even if Creighton had 300, UNMC probably would have wagered judiciously.
Yeah. And I see lots of smiles at Creighton, so I think the sportsmanship is good and everybody had a good time. So
no bitterness, guys.
Point, right? Okay, so I'm going to go ahead and go to the final Jeopardy. If I can open it here, let's see. This worked before, but that's okay. I can do this another way. I've got a photograph. What I have is, this is images in clinical medicine, and I'm guessing that some of the senior faculty will have seen this in the past. It's a kind of a famous image, but I've got a question that relates to the image that I'm going to display here. And since I'm not asking you to wager, I'm just going to pull up the slide, and I'm going to try to not also show the answer at the same time. So I'm going to kind of sneak up on it, if I can possibly do that. Bear with me. Okay. So this image in clinical medicine is an informal portrait of a 5-month-old boy and his 30-month-old brother that demonstrates a commonly sought but uncommonly found physical exam finding. What is that physical exam finding? You can discuss quietly amongst yourselves, and I'll give it a minute or so. I'd be doing it, but I know that my link to the Jeopardy sound doesn't work. So I'm sure we're all humming it in our heads right now.
UNMC appears to be ready. We'll give Creighton maybe just a couple more seconds here. Maybe give us a thumbs up, teams, when you think you guys are ready.
All right. Well, I'll start with Creighton, just since they're a little behind. So Creighton, what would you guess is the physical finding that's exemplified in this portrait? No guess? That's okay. I'm going to go ahead and go to UNMC.
Is it, okay.
No risk here.
You think it is? Just say whatever the sandal toe is. So yeah, are you looking at his toe like a sandal toe? I can't tell with.
Is that your answer?
Yeah, sure.
Okay. You're close. You're in the right area, but there's something going on there that we often try to elicit in physical exam.
You talking about is upgoing Babinski?
There you go. What they noticed is that his toe of his right foot is gently stroking the palmar surface, and then the toe is upgoing. This was kind of a famous photo from New England Journal a few years back. There was a little debate about the validity of the finding and things like that, but the whole point was it appears that's going on, and the fact that Babinski reflex extinguishes as we grow out of babyhood. But so close. Babinski sign would have been the correct answer, but I would like to congratulate Nebraska UNMC on their winning of this year's Doctor's Dilemma. Great job, guys. It was a good competition. It was those minuses that killed us. So at least everybody was willing to make some stabs at some guesses. So give me a little better perspective for next year as we work on content. So appreciate it.
Yeah, thank you.
Appreciate Dr. Fox. Obviously, putting those questions together is a little bit of labor of love. So we appreciate you doing that. And for both teams, great competition, and even got some crowd participation too. So that was great. So, well, we are really at the end of the annual meeting for the Nebraska chapter. I want to thank everyone for being here. And before I forget, I want to thank sort of the 3 C's that allowed us to be successful today. So that would be Carol, Casey, and Cindy, and their sort of all their hard work in putting this together. It might seem like doing a virtual, half-day session would be pretty easy, but I think you just have to trust me that there's been a lot of effort behind the scenes to make this go actually really, really seamlessly in my estimation. So a big thanks to all 3 of them. So there is going to be, the opportunity to do an evaluation and claim any CME for this, depending on what you participated in today on kind of the splash page for this particular meeting. And look out for upcoming events, specifically if you want to become involved with the mentorship program that was highlighted earlier. Otherwise, enjoy the rest of your day, and thanks for everyone being here.
Great job. Thanks, Micah.
Thanks, Devin. Appreciate it.
Great job.
Thanks, Suzette.
Bye.
See ya. Have a good rest of your day.
Thank you.
Casey, do you need anything else from Nate or I? Think things went really well.
Yeah, I agree. I thought it was seamless, like you said. I thought all the videos played well and
Yeah,
everybody did a good job.
yeah, I
I'll get
appreciate all your efforts.
Yeah, thank you for putting those polls together. That was really helpful to
Yeah.
just be able to flash those up real quick.
Yeah.
Agreed. I'll get the gift cards out to the winners as well as the chapter award winner plaques. I'll deliver those next week.
Okay.
But yeah, thank you both. I thought you both did a great job too.
Appreciate it.
Casey, do you have postcard or the thank you notes and stuff that I can swing by the office at some point and start
Yep.
working on those?
The only thing we printed out some cards here. So these are ready to go. The only thing I don't have done are I was going to put the addresses on the envelopes. So
Oh, okay. Yeah.
That done, but I'm going to do that. I plan to do it Monday. So anytime
Okay.
after Monday, you can stop by and I'll get those out.
All right. Perfect. Sounds good.
Thank you
Well,
both.
everyone, enjoy the rest of your day. Thanks for all your efforts. Again, I think that went really well, and I was pleased with the attendance too. That was nice to see.
Me too.
Yeah, it was good.
So-
I was happy that there was good votes for the Nebraska City kind of thing too. That seemed like that had some strong interest
Yeah.
at least. So that was
Yeah,
awesome.
so it looks like this all day Saturday was, the votes were leaning towards that. So
Yeah, more one day. So we at least helps us sort of think about how we make arrangements for next year. So
yeah, so when do we want to reconvene on actually? Do you want me to put out a poll to like through the ACP? Like send out an email asking people, you know, because we had 34 people here today,
right,
but
you try to get greater. Maybe just narrow it down to just, what's your interest level for this weekend at Lead Lodge on Saturday only. I think we sort of narrowed it down to that based on the based on the survey we did so far. So yeah, I'd be fine sending out a broader survey if you want.
Can we reserve just the conference area without necessarily having to reserve a block of rooms then? Is that an option?
yeah, I can talk with her next week at some point to ask what our options are. I would think so, because I think people have conferences there all the time that don't require an overnight stay.
Sure.
Or, that some of the people would want to stay overnight. And some
Participants,
people may.
participants might want to do that themselves anyways, if they're
Mhm.
down there and make it into a family thing.
Yeah.
Right.
Okay.
Yeah, I don't know. Casey, do you feel like we need to get together before kind of Thanksgiving or sort of shortly after to kind of start making some preliminary plans for what that might look like?
I do. I think maybe getting the meeting, or do you want to start out with just the three of us or getting the meeting planning committee together too?
I would assume that to a certain degree, we'll need kind of a rough framework for what that day might look like to think about how we want to fill it with speakers. I don't know, Nate, do you have a preference? You want to just start with us, kind of outline what we think it might look like, and then engage the broader committee, or do it all at once?
Yeah, I think probably get kind of a rough outline first, and then we can
Okay.
roll it out later to the broader committee.
So maybe the three of us try to meet sometime in the next couple weeks, and then the broader group is early December kind of thing.
Yeah, that sounds good.
Carol too.
Yeah, we can
Hey,
find
Carol.
out time to get together.
Okay. Yeah, I'm pretty much free anytime. I'm going out of town next week, Thursday through Friday, or Thursday through Sunday. So anytime before Thanksgiving. the exception of those dates. I'll send something out. And we'll get a Zoom meeting together. I think we could probably do
Yeah.
that.
Perfect. Sounds good.
Thanks so much, guys.
Yeah.
Thank you.
both. Yeah, great job
See
today.
ya.
Good afternoon.
Go
Good luck with
Huskers.
that. Yeah. All right, bye-bye.
All right, see you. Bye-bye.
Bye.